Sir.
Yes.
Yes, sir. I am starting the lecture, sir.
Yeah.
Good evening, sir. Good evening, all. Today, I want to present the topic compartment syndrome. Compartment syndrome is a condition in which the circulation within a compartment is compromised by an increase in the pressure within the osteofacial compartment, causing necrosis of the muscle, nerves, and eventually the skin because of the excessive swelling. The compartment syndrome was first report of this condition was attributed to the Hamilton in 1850. In 1881, Volkmann described the contracted state believed due to the ischemic muscles. Then in 1884, Laser developed the clinical model of the compartment syndrome. After a few years, 1906, the Hildebrand coined the term Volkmann's ischemic contracture, or the contracture of the muscle caused by the ischemia of the muscle. Then in 1940, Murphy recommended fasciotomy to prevent the contracture. It was the treatment for the acute compartment syndrome. In 1940, the Griffith described the 4 P's. In 1967, the Whiteside traced 4 compartment fasciotomy for the compartments of the leg. Compartment syndrome can be divided into 2 types mainly: acute compartment syndrome and chronic exertional compartment syndrome. The third one, Volkmann's ischemic contracture, is actually the complication of the acute compartment syndrome. Now the definition of acute compartment syndrome. Acute compartment syndrome is defined as the elevation of the intracompartmental pressure to the level and for the duration that without the decompression, it will cause the tissue ischemia and the necrosis. Now chronic exertional compartment syndrome. It is the elevation of the intracompartmental pressure during exercise causing ischemia, pain, and rarely neurological symptoms and signs. It is characterized by the resolution of the symptom with the rest. So it is different from the acute that the chronic exertional compartment syndrome, it is relieved by the rest. Now Volkmann's ischemic contracture, it is the end stage of the neglected acute compartment syndrome with irreversible muscle necrosis and leading to the ischemic contracture of the involved muscles. Now acute compartment syndrome. The most common cause is the fracture, with tibia fracture being the most common amongst all fracture. It is followed by the fracture of both bone forearm, and it is followed by the supracondylar humerus, especially in the children. It can also cause by the soft tissue injury, and impact increases if soft tissue injury is associated with any fracture. Then crush syndrome, burns, snake bites, any arterial injury. Nephrotic syndrome can also cause the compartment syndrome, and last, the exercise can cause the chronic compartment syndrome. Now we try to understand the etiopathogenesis of the compartment syndrome. Whenever any trauma occurs, it leads to the arterial occlusion and the arterial spasm. The occlusion of the artery leads to the muscle ischemia. Now, ischemic muscle will release histamine, which itself cause the capillary increase in the capillary permeability. And due to increase in the capillary permeability, there will be the intramuscular edema. Now, the fluid collected inside the intramuscular compartment, so the intramuscular pressure will increase. The increase in the intramuscular pressure can cause venous, lymphatic, and arterial compression. So ultimately, again, due to increase in the intramuscular pressure, the arterial flow decreases, and the cycle goes on. This vicious cycle ultimately leads to the muscle and nerve ischemia, which is the which can cause the ischemia of the muscle and necrosis of the muscle. Now, there is a theory of AV gradient theory, which explains the cycle of the acute ischemic contracture. According to this theory, the increase in the local tissue pressure reduces the local arteriovenous pressure gradient. The arterial pressure remains the same, but the venous pressure increases due to the increase in the intracompartmental pressure, and thus reduces the blood flow. when the blood flow diminishes to less than the metabolic demand of the tissue. It is not necessary that the blood flow goes to the zero, but when it reduces to the metabolic demand of the body through muscle, then the functional abnormality will usually result. Now, what is the commonest sites for the compartment syndrome? The most common being the leg compartment syndrome. It is followed by the hand compartment syndrome, forearm compartment syndrome, foot compartment syndrome. Thigh and arm compartment syndrome are among the rare compartment syndrome. Practically, it can occur in the any compartment, any muscle which is included in the any compartment. Now, it is important to know the tissue threshold to the ischemia. The muscle is most vulnerable tissue to the ischemia. It takes only 4 hours to start the permanent necrosis of the muscle. It is followed by the nerve, which can withstand the ischemia up to 8 hours. Fat can withstand up to 12 hours, skin for 24 hours, and bone can withstand the ischemia for 72 to 96 hours. Therefore, the viable functional limb, the upper threshold is only about 6 hours because muscles and nerves are usually in this range only. How to diagnose the compartment syndrome? The diagnosis is usually clinical. The main symptom is deep aching pain. The main point is it is out of the proportional to the injury. The injury will be minor, but the pain will be out of the proportional to the injury. Pain will be severe. The signs include the incredible pain on the initial passive movement of leg. It is due to the stretch out of the ischemic muscle. Whenever we try to stretch the ischemic muscle, it can cause the initial stretching pain. So it is the most valuable sign for early diagnosis of the compartment syndrome. Now you have to see the pulselessness. Is the arterial supply is cut off? Check for the pulse. Check for the paresthesia distally. Check for the pallor. Check for the perishing cold limb. Limb should be cold. Limb will be cold. Paralysis can occur if the presentation is late. Tight swollen limb you can see. There will be redness, mottling or blister formation. The classical sign 6 P's may or may not be present. It cannot exclude the condition based on their absence of the 6 P's. Now, first sign pain. Pain is classically out of the proportional to the injury. It is exaggerated with the passive stretch of the involved muscle in the compartment. It is earliest symptom, but it is inconsistent. The pain only cannot diagnose the compartment syndrome. It also cannot rule out. Pain is not, you cannot feel the pain in obtunded patient. Now, pallor. The extremity may appear cyanotic or mottled early in the course of the events. The cyanosis is present early, whereas the marked pallor in the distal extremity occur late because the marked pallor occur only when there is a major arterial occlusion was occurred. Neither pallor nor the cyanosis should be considered as the sign that is necessary for the diagnosis of the compartment. The compartment syndrome can occur in good-looking limb also. Other sign, paresthesia. Paresthesia is also an early sign. The peripheral nerve tissue is more sensitive than the muscle to the ischemia. We have seen that the muscle can withstand the ischemia up to 4 hours. Nerves can withstand up to 8 hours. But the peripheral nerves, the permanent damage can occur within 75 minutes. So it is, but it is difficult to treat, and it will progress to the anesthesia if pressure is not relieved early. Next one is paralysis. Development of motor dysfunction suggests that the ischemia has been already established and permanent damage has been occurred. The irreversible muscle fiber changes occur as early as 6 hours after the onset of tissue ischemia. The other sign, pulselessness. The loss of palpable pulse has been shown to occur late or sometimes not at all. The pulse may be palpable even after a compartment syndrome has been setting. Clinical experience and the experimental evidence verify that irreversible tissue damage can occur in a patient with the palpable pulse. So if you are feeling the pulse, then it is you cannot rule out the compartment syndrome. You have to check for other clinical symptoms and signs. Now, what is the methods to measure the compartment syndrome? When compartment syndrome is suspected and the necessary equipment is available to your hospital, compartment pressure should be obtained to confirm your clinical diagnosis. Now, what is the criteria to what is the criteria to say that this is compartment syndrome? The compartment pressure over 30 mm Hg or the pressure within 20 mm Hg of the diastolic pressure. These two criteria are indicative of compartment syndrome. Either 30 mm Hg compartmental syndrome or 20 mm Hg of the within the 20 mm Hg of the diastolic pressure of the patient. Now, this is the white side technique to measure the compartment syndrome. It is the simple apparatus. It is a 3-valve phenomena here. Okay, it has a 3-valve phenomena here. The syringe is attached, which has air in it. The other tube is attached with the needle, which is inserted in the compartment. This tube is attached with the mercury manometer. Usually, there will be water within the manometer. So what we do, we start pressurize the syringe. So the pressure will be equally distributed in needle and manometer both. So the pressure, the time occurs when the pressure exceeds the compartmental pressure. At this pressure, what happens in the mercury manometer? The water level is usually concave in nature. The water level of the mercury manometer will be concave until the compartment pressure is reached. When the compartment pressure reached, the pressure will be more lateralized on the mercury side. So the superficial surface of the water will be straight instead of the concave. So at this point, you can say that this is the compartmental pressure. Then read the indicator there, and this is your compartment pressure. Ready-made striker stick handheld manometer are also available. You just have to insert the needle in the compartment, and you will get the reading in your monitor. In most of the practical scenario, the diagnosis of the compartment syndrome is essentially clinical. So we diagnose mostly clinical. In our hospital also, we are not using any instrument for diagnosis compartment syndrome. With all the investigation is just aiding to the your diagnosis. Now, treatment for acute compartment syndrome. The treatment of acute compartment syndrome is fasciotomy, and fasciotomy. The impending tissue ischemia may be considered when the tissue pressure reaches between the 30 and 20 mm Hg below the diastolic blood pressure. If there is a pressure of 30 mm in compartment syndrome, or the pressure is just 20 mm Hg below your patient's diastolic blood pressure, then you can say it is a compartment syndrome. As a general rule, whenever you are in doubt about the compartment syndrome, the compartment should be released. If it proves later that it was unnecessary, there was no acute compartment syndrome, only the scar will result. But if, however, if the fasciotomy should have been done, but was not done due to you are not sure about the compartment, then there will be the devastating results like a loss of muscle tissue, and worse maybe result like amputation also. Fasciotomy should be performed in. What are the criteria for the fasciotomy? First, the normotency patient with positive clinical findings and compartment pressure of greater than 30 mm Hg, and when the duration of the increased pressure is unknown or thought to be longer than 8 hours. So the compartment, if you are thinking that the compartment was lasting longer than 8 hours, then you have to do the fasciotomy. Second, in uncooperative or unconscious patient, you cannot evaluate the clinical signs. So you have to measure the compartment syndrome. So if there is a compartment syndrome more than 30 mm Hg, do the fasciotomy. Third criteria, where the patient who are with low blood pressure, and you are not getting 30 mm Hg pressure in the muscle fascia, but even there is another criteria, take 20 mm Hg below the diastolic blood pressure. So it is your pressure to diagnose the acute compartment syndrome. If it reach above the 20 mm Hg below the blood pressure, just do fasciotomy. So these are the indication of fasciotomy. This is the flow chart. We try to elaborate the flow chart. If you are suspecting compartment syndrome and you are finding equivocally clinical positive finding, do fasciotomy. There is no need that you have to measure the compartment syndrome. If you cannot diagnose clinically, and either your patient is not alert, unreliable, polytrauma patient, so your clinical finding may be inconclusive. In this case, what you do, you measure the compartment pressure. So if compartment pressure is more than 30 mm Hg, do fasciotomy. If compartment pressure is less than 30 mm Hg, so you have to continuously measure the compartment pressure with severe clinical evaluation and both the compartment pressure evaluation. If in the course of this evaluation you find that there is a clinical diagnosis to confirm the compartment syndrome, do fasciotomy. In the course of this, if you find that at any point the pressure is more than 30 mmHg, do fasciotomy. And if pressure you are finding less than 30 mmHg, then continue your evaluation. Now, most important statement: a delay in the diagnosis was the most important determining factor for the poor outcome. If the fasciotomy have done in the time, the prognosis is usually very good. Now, fasciotomy of the leg. There are three approaches have been described in literature to release the compartment of the lower leg. First, double incision fasciotomy, single incision fasciotomy, and the other one is fibulectomy. What we do in single incision fasciotomy, we make a full length incision from knee to ankle on lateral side. We try to open all the compartment. That is, there is a four compartment in tibia: anterior. This is anterior compartment. This is lateral compartment. There are two compartments on posterior side. This is the superficial posterior compartment, and this is the deep posterior compartment. What we do, we make the incision on the lateral side, and we try to open up all the compartment from the lateral incision only. This is the single incision fasciotomy. This is the clinical picture showing the single incision fasciotomy. Now, double incision fasciotomy. The single incision fasciotomy was cumbersome due to in one incision it is sometimes not possible to reach all the compartments. So what nowadays we are doing, we are putting two incision: anterior lateral incision and posterior medial incision. Posterior medial incision to open two compartments, both posterior, superficial posterior and deep posterior. And in anterior lateral compartment, through anterior lateral incision, we are opening two compartments: anterior compartment, this, and lateral compartment. So it is a double incision fasciotomy. Then third described is the fibulectomy. You just have to remove the fibula around the head of the fibula, and all compartment will automatically get released. Now, this is the typical fasciotomy closure. This technique is called as shoelace technique. It is like how you tie your shoe. It kept open so that the fluid which are collecting inside can come out. This figure shows the forearm fasciotomy. In forearm also it can divide it into superficial volar compartment, deep volar compartment here, then dorsal compartment, and mobile wed. So we have to release all four compartment if it was involved. There are fasciotomy described to release the compartment of the forearm. This is the Hendry's approach. Hendry's approach to open the volar compartments of the forearm, and this incision given to open the compartment on the dorsal side, and this is for the volar side. Clinical picture of Hendry's approach. This is the clinical picture for Hendry's approach. We are starting from here and extending up to the elbow. Now thigh fasciotomy. Thigh has the three compartments. That was anterior, medial, and posterior. So it is the skin incision given on the lateral side of the thigh, full incision from the trochanter to almost the lateral condyle. So we are opening all the compartment: anterior compartment, posterior compartment. This figure showing, this is the anterior compartment. This is lateral intermuscular septum, which divides the anterior compartment, and this is a posterior compartment. Then posterior intermuscular septum divides the posterior compartment and medial compartment. It all has to be released if you are suspecting compartment syndrome in thigh. Again, the shoelace technique to close the wound of the fasciotomy. Now, what are the disadvantages of fasciotomy? The closed fracture you are suspecting, in which you are suspecting the acute compartment syndrome. If you are doing fasciotomy, then you are converting your closed fracture into compound fracture by opening the wound, and loss of the stability due to opening of all the fascia. This can occur due to fasciotomy. Management associated with fracture. If you are doing fasciotomy in the fracture patient, the fracture stabilization should be performed after fasciotomy. The stabilization of the fracture allows easy access to the soft tissue, and protect the soft tissue, permitting it to heal. Now, wound care for the fasciotomy. Now, what care you have to take? The soft tissue coverage should be done by 5 to 7 days of the fasciotomy. Until then, only the shoeless stitches will be there, so the oozing can come out from this stitch. After 5 to 7 days, you can cover it. Delayed closure can be done by, if you have to delay the closure due to continuous of the oozing and continuous of the compartment syndrome, that you have to do the delayed closure. It can be done by vascularized loop less technique. You can also use split thickness skin graft. You can use flap or free tissue transfer if it was required as per the patient's requirement. What are the prognosis of compartment syndrome? It is very good prognosis if diagnosed in the time and timely fasciotomy is done. So it all depends on the time we will diagnose the fasciotomy and you take the patient to the OT. Delaying the diagnosis is the most common cause of the poor result, with the significant sequelae, including it can cause muscle neck contracture, muscle weakness, sensory loss, infection, non-union of the fracture, and in severe case, even the amputation due to the lack of the function. If you are not doing timely diagnosis of the compartment syndrome, you have to be ready for the amputation. Now, this is all about the acute compartment syndrome. Now, other entity is chronic exertional compartment syndrome. Chronic exertional compartment syndrome is defined as the reversible. It is a reversible ischemia secondary to the non-compliant osteofascial compartment that is unresponsive to the expansion of the muscle volume that occurs within the exercise. So what happens while doing the exercise, the pressure in the compartments increases and it can cause pain chronically. So it is known as the chronic exertional compartment syndrome. It is usually associated with any exertion. Epidemiology. It is common in young recreational athletes, new military recruits, elite athletes. So all included in the any type of exertion. The anterior and lateral compartment of the leg are most affected in this chronic compartment syndrome. The symptoms are usually bilateral, almost 75% of patients. The 2-year delay in the diagnosis is typical for chronic exertional compartment syndrome. Usually the diagnosis was delayed. Now, how to diagnose the chronic compartmental syndrome? You have to measure the compartment syndrome. You cannot diagnose clinically. In pre-exercise, resting pressure of 15 mmHg or more. If the patient is resting and you measure the pressures to be 50 mmHg or more, this is the case of chronic exertional compartment syndrome. If the pressure rises up to the 30 mmHg within the 1 minute of exercise, it is chronic exertional compartment syndrome. And third criteria is pressure of 20 mmHg or more after 5 minutes of exercise. If the patient do 5 minutes of exercise, then you measure the compartment syndrome. If the pressure is 20 mmHg, then it is chronic exertional compartment syndrome. So these three are the criteria for diagnosis. The treatment is mostly conservative. Most patient responds to the conservative treatment very well. What you can give the anti-inflammatory for relief of the pain. If there is a pain, give the rest. Passive muscle stretching exercises and structural strengthening physio exercise. This will be sufficient to relieve the chronic exertional compartment syndrome. If it is not relieved by the conservative means, after some period of time, then you have to do the fasciotomy. The typical fasciotomy described by in literature was double mini incision fasciotomy. What we do, we put two vertical 2 centimeter skin incision here and here. The two vertical incision will be given on the lateral side of the thigh. Development of the subcutaneous flat with the blunt dissection. We do blunt dissection from here and here. So we'll meet inside. Then skin retraction to allow the fasciotomy under the direct vision. Retract the skin, see the fascia and cut the fascia. After cutting the fascia, just do the wound closure. This is the figure showing the wound closure of the double incision fasciotomy. It can give the best result, and after this fasciotomy, the problem of the chronic exertional compartment syndrome usually resolves. Thank you, sir.
Thank you. Thank you, Nimesh bhai.
Yes, sir.
Good.
Yes, sir. Thank you.
Any questions from the people who are attending?
Mute.
Okay.
Yes, sir.